Hello everybody, my name is Dr. Sanjeev Sockalingam, psychiatrist at the Toronto Western Hospital Liver Centre and assistant professor at the University Health Network at the University of Toronto. It is my pleasure to be speaking to you today about a study we recently published in the Journal of Hepatology focusing on treatment adherence in autoimmune hepatitis and psychosocial factors that may be associated with adherence and response. As many of you know, autoimmune hepatitis is an inflammatory disease of the liver, and immunosuppressive therapy is the mainstay of treatment. In fact, prognosis with autoimmune hepatitis is significantly worse in patients who are non-adherent to immunosuppressive therapy. As a result, we have explored the literature to determine, in fact, if other studies have been done examining psychosocial burden in autoimmune hepatitis patients, and also the potential impact of psychosocial factors on treatment adherence. We recognize that psychosocial factors are one component of treatment adherence in patients with autoimmune hepatitis, but we also acknowledge that psychosocial factors are often under-recognized or underreported in patients in cross-sectional studies in the literature. As a result, in our study, we sought to determine the effects of psychosocial factors such as depression, anxiety, and relationship style, particularly avoidant relationship style, and their impact on treatment adherence to immunosuppressive therapy in autoimmune hepatitis, as well as treatment response. We also aimed to quantify the psychosocial burden in patients with autoimmune hepatitis, as this has been understudied in previous literature in autoimmune hepatitis patients. As part of our study, we consecutively recruited 52 autoimmune hepatitis patients from the Liver Centre here in Toronto. We administered a variety of tools to determine psychosocial burden, including the Patient Health Questionnaire 9, which looks at depression, the Generalized Anxiety Disorder 7, which looks at anxiety symptoms, as well as the Experiences for Close Relationships 16-item scale, which looks at relationship style, which is a state-dependent trait that really quantifies the nature of the relationship that one has with others in their social support system. And it quantifies relationship style into anxiety and avoidant spectrums. We also looked at treatment response, and our hepatologist within our clinic, Dr. Hirschfield, examined the biochemistry and liver enzymes of all 52 patients to determine if they met criteria as per treatment guidelines for remission or, more importantly, response in terms of autoimmune hepatitis. We then subsequently analyzed the data using comparative t-tests as well as categorical variables were examined using chi-square. In our study results, we found two important findings. First, that treatment response was highly linked to treatment adherence, and that treatment response was also linked to higher anxiety. That is, poor treatment response was noted in patients with higher anxiety, and poor treatment response was also associated with greater avoidant relationship style. The second important point which we found was that treatment adherence was also related to psychosocial factors, in particular, patients who scored higher on anxiety, depression, and avoidant relationship but not anxious relationship style had worse treatment adherence, and that was defined as a less than 80% treatment adherence to immunosuppressive therapy. In addition, we also showed that steroid treatment, and particularly with prednisone in our sample, did not significantly increase the psychosocial burden in our patients. In our overall sample, patients had a moderate anxiety and moderate depressive symptoms in approximately 12% and 15% of patients respectively. Despite the findings not showing an influence on steroids, there was a slight trend to higher depressive symptoms in the patients who were treated with steroids as opposed to the non-steroid group, although this did not achieve significance. So what can we take from the study findings? Well, first, we can definitely appreciate that psychosocial burden is important and highly prevalent in patients with autoimmune hepatitis. Secondly, we see a strong link between treatment adherence and treatment response in patients with autoimmune hepatitis. And then third, we see that psychosocial factors, particularly depression and anxiety, which have been seen in other medically ill patient populations, but also avoidant relationship style, can also negatively impact treatment adherence and subsequently treatment response. What does this mean clinically? Well, first, I think what it means clinically is that as we see patients in hepatology clinics, in gastroenterology clinics, or primary care who may be suffering from autoimmune hepatitis, that patients should be screened in terms of psychosocial factors when they are encountering non-response to treatment regimens. And I think this should be explored before we start moving on to changing treatment therapies. I think this also underscores the need for further psychosocial research in terms of factors that can influence adherence, as psychosocial factors may be responsible for a non-response. And I think this might be an important body of research to further explore, in addition to looking at newer therapies for autoimmune hepatitis. Why are patients who have who are non-adherent to autoimmune hepatitis more likely to have anxiety and depression? Well, I do think it's a bidirectional relationship. I think first that patients who are non-adherent may be more likely to suffer more disease burden and may be at a higher risk of having anxiety and depressive symptoms. But I also think there's a large body of literature from other chronic medical illnesses where depression and anxiety may impact treatment adherence through a variety of mechanisms. Patients who are anxious may be less likely to be adherent to treatment regimens due to fears about side effects. Patients who are depressed may be less motivated or have difficulty remembering or having concentration difficulties, which can impact their ability to comply with treatment regimens, particularly when they include multiple pill regimens. Further, I think one important finding clinically is that although our study did not show a significant difference in psychiatric symptoms in patients on steroids and off steroids, I think for autoimmune hepatitis it's important to consider non-steroid-based immunosuppressive therapies in patients who may be at risk of these psychiatric symptoms. So azathioprine may be an alternative, or if steroids are needed, budesonide may be an alternative to prednisone due to its lower theoretical systemic effects and lower theoretical neuropsychiatric symptoms. We do need further research to further clarify and substantiate this lower risk, but until we have these findings, this may be a treatment alternative for patients who may have this psychosocial burden. So in summary, I think it's important for us to consider psychosocial factors when we're looking at treatment adherence, but also treatment response, and particularly non-responders to autoimmune hepatitis treatments. I also think that it's easy to start screening for these symptoms with similar tools that we used in our studies, such as the Patient Health Questionnaire 9 or the Generalized Anxiety Disorder 7. These scales are readily available, easy to administer, and have a validity in a variety of medical contexts, and now, as per our study, have been useful in quantifying depressive and anxiety symptoms. We hope that this study has been additional value to your clinical practice and also been an interesting finding for you and may serve as the foundation for further research going forward. Thank you for listening, and we hope you enjoyed the article.